There we go. Thank you.
No problem. Well, thanks everyone for joining. I think we've got about 45 minutes and then 15 minutes for questions, and I will try to certainly leave some time. Before I really dive in here, I just want to acknowledge that this work is part of a huge collaboration with tremendous colleagues that I have here. What I'm excited to share with you about today is part of a program of research that really includes students and collaborators from across the University of Minnesota and really our state, and growing connections with some of you on the call today across the country as well. I feel really lucky to be a part of an amazing group of practitioners, including Erica Garrity, who is program director and founder for the Minnesota Prison Doula Project, and Ray Baker, who is our program coordinator. And these two women are just deeply committed to doing good work every day with incarcerated pregnant people. So what I'm sharing today is part of our collective work. So I just want to put that out there. So it's really, this topic, when we think about pregnant incarcerated women, is growing in what we see in the popular press now almost every single day, it seems like. It's probably come as no surprise to folks that are on this call, but this is something that we're seeing in our popular media. This is a story from National Public Radio that talked about a large Department of Justice settlement for the Alabama Department of Corrections. They have made recently considerable reforms, particularly for women's services in that facility and across the state. Of course, we've seen things in the New York Times, this article looking at pregnant inmates in particular, and whether or not they should be housed in correctional facilities at all. Getting more specific, thinking about the intersection between incarceration and the opioid epidemic and what that means for pregnant women in particular. And then other recent articles thinking about breastfeeding. And so what do we know for incarcerated mothers in the postpartum period and breastfeeding? And so I want to kind of put this big backdrop on what we're thinking about here today, and recognizing that this really is a conversation that is happening now all around us and is something that is growing in national attention. And I think we have a lot of opportunities to collaborate with local public health and folks on the call to really elevate this topic. I just want to pause for 1 second. It sounds like at least one person has asked that I move closer to the mic because the audio is pretty faint. I just want to make sure that everybody can hear. Is that right?
Hi, Rebecca. It is a little faint, so if you could move a little closer and maybe speak just a little bit louder, that would be great.
I'm going to try to take it off speakerphone and just use my phone.
Perfect. Are you still there, Rebecca? Are you there, Rebecca? So it seems she may have dropped off the line. Let's give her a minute here to get back in. And sorry about the beeping, everyone. What you hear are people joining the call. So I went ahead and muted that, so that should take care of that background noise. And Rebecca, if you are on, you might be muted. You can press *7 to unmute yourself. Okay. Otherwise, we'll just give her a minute here to get logged back in.
Can you hear me?
Yes.
And is the volume better?
I think it is.
Okay.
It's a little louder.
All right. Well, we'll let somebody chime in via the chat window if this isn't louder, and we'll see. Oh, Grace says thank you. Okay, good. Well, we will just jump right in, back in here.
Perfect.
Sorry about the technical difficulties, everybody. So
I think a lot of this works, and when Reagan reached out to me and asked if I would participate in this call today, really recognizing that many of you are interested and invested in reproductive justice. And so I just wanted to orient our time together to thinking about Ross's framework around reproductive justice and Sister Song's work in this area, and thinking about this as a framework for us to move forward together this afternoon. So reproductive justice, right, being defined as the human right of every person to decide if and when she will have a baby and the conditions under which she will give birth. This is, of course, incredibly relevant when we think about pregnant women, and even prior to that, thinking about whether or not women have access to pregnancy tests in correctional facilities if and when they are identified and notified of their pregnancy, and contraception and full-spectrum reproductive care, and then for pregnant women, the conditions under which she will give birth, which as we move forward in today's time, you'll see that there are very few circumstances in which in a correctional setting, incarcerated women have options or control over conditions under which they're giving birth. The second piece of this, deciding if she will not have the baby and her pregnancy and her options for preventing or ending the pregnancy, certainly considerations for incarcerated women. And then the third piece of a reproductive justice framework is the human right of every person to parent her children with the necessary social supports in safe environments and healthy communities and without fear from violence from individuals or the government. And I think this is particularly relevant for this population when we consider that incarceration in the overwhelming majority of the states inherently separates mothers from their children, and one's ability to parent is very much compromised by the criminal justice involvement. And this particularly for mothers who will give birth in custody, in the overwhelming majority of states, with the exception of those that have prison nurseries, mothers will be separated from their infants within about 48 hours of the delivery. And so again, thinking about this reproductive justice framework is really important when we are reflecting on this issue. So I think we've got folks on this call who may know very little or a lot, a huge range in terms of knowledge of the criminal justice system. And I wanted to provide just a little bit of background about what do we know about incarceration and women in the criminal justice system in general. And I think this is an important place to start. So what you see here on this slide is the U.S. state and federal prison population from 1925 to 2014. And what you can see is just this exponential growth in the number of people that we have incarcerated in this country. So despite violent crime dropping, we've seen exponential increase in the number of people who are incarcerated in state and federal prisons. And we know that these increases have been largely attributed to changes in criminal justice policies, including mandatory minimum sentencing for drug convictions. And we know that those changes in policies have disproportionately impacted communities of color. So today, the U.S. has 5% of the world's population and 25% of the world's inmates. I'm sure a statistic that many of you have heard in a variety of settings. And I think it's important for us to remember that it is costing us as taxpayers $80 billion a year. This is really an issue that not only has, when we think about mass incarceration, disproportionately impacted communities of color, but we've also seen actually women, the number of women going to prison, increasing at a faster rate than men. So I've added to this slide here, you can see the uptick in the number of women who are incarcerated in state and federal prisons over a similar time period, and you can see just this astronomical growth over about a 30-year period in terms of the number of women who are incarcerated in state and federal prisons. I think it's also important to recognize that women are locked up in other places beyond just state and federal prisons. In fact, this image here from the Prison Policy Initiative I like to show, and I think it's important kind of as a criminal justice 101 in thinking about the differences between local jails, state prisons, and federal prisons. So local jails are local correctional facilities, typically in county correctional facilities. These are for folks that are pre or post adjudication, pre meaning pre-trial, so these are individuals who are not yet convicted. And you can see on this image here that there are a sizable proportion of the 96,000 women locked up in the United States that are in jails that have not yet been convicted of a crime, 58,000 of them. Another 38,000 of them in local jails are convicted, and they are going to be serving likely shorter sentences. Those women may be in their county jails waiting to go to a state prison or waiting to go to another facility, or they may be sentenced to a lower level crime like a gross misdemeanor where they're going to be serving, usually the cutoff is approximately less than a year. State prisons, in contrast, are state-run correctional facilities. So here in Minnesota, we have several men's facilities and our one women's state prison, the Minnesota Correctional Facility, Shakopee, which you'll hear about in a bit. So a good portion of the pie, just under half of it, of across the United States are women who are incarcerated in state prisons. And you can see a smaller proportion are federal prisons. These are run by the Federal Bureau of Prisons, the BOP, and those are for individuals who are convicted of federal felony level offenses. So again, difference between these correctional facilities, and this becomes important when we think about the implications for pregnant and parenting women. People talk about local jails having a high rate of turnover. The average stay is very short. Most correctional folks in local jails will tell you their average stay is, between 10 and 14 days. There's a lot of churning that happens in local county jails. That makes it challenging from a public health perspective to think about any kind of sustained intervention or really any kind of identification. This is really hard when we're thinking about identifying pregnant women, for example. If the churn is very fast in a county jail, a woman may be released before she's even identified as pregnant, or certainly challenging in thinking about how one gets engaged in services if she is incarcerated for such a short period of time. And differences when we think about implications for public health in terms of state prisons versus federal prisons. Federal prisons are all over the country, and often women as well as men are housed thousands of miles away in federal prisons. In our state of Minnesota, with only one women's prison, every single woman who's committed and convicted of a felony level offense is incarcerated at Shakopee Women's Prison, which is just southwest of the Twin Cities area. Now that means that some incarcerated women, they're housed, again, hundreds of miles away from their children. And so the implications here when thinking about prevention and intervention and opportunities for local public health is really challenged depending on where someone is incarcerated. So I think that's just an important kind of lay of the land to think about here in terms of who are we talking about and the different correctional facilities we're talking about. I'm going to turn now to really thinking about this group of incarcerated women and what do we know about them. So let's think about the more than 100,000 women in state and federal prisons across the country. What do we know about them in terms of the data? When we think about incarcerated women in state prisons, we know that 75% of them, at least 75% of them, are of childbearing age. Nearly 2/3 of them are mothers with minor children. And national, although very dated estimates from the Bureau of Justice Statistics indicates that 3 to 4% of them are pregnant upon their admission to prison. I want to make a note here about numbers because for a long time here and still to this day, we have very poor data in terms of pregnancy, really surveillance data in terms of pregnancy for incarcerated women. And my colleague, Dr. Carolyn Suffren at Johns Hopkins University, is really tasked lately. She has been doing this incredible project called the Pregnancy in Prison Statistics Project, really with the goal of gathering national scale statistics on pregnancy outcomes for people who are pregnant while incarcerated. Dr. Suffren just wrapped up data collection, and she anticipates releasing results from this study here pretty soon. I think it's important to recognize that this included 22 state prison systems, 6 jails, including 5 of the largest across the country, and 3 departments of juvenile justice that are reporting on a monthly basis, or were reporting on a monthly basis, on the number of pregnant people incarcerated in their facility and the outcomes of those pregnancies, whether those were births, miscarriages, abortions, stillbirths, and other pregnancy outcomes. And I can provide Reagan and others with the link to this page here, but it's pipsdata.org, and Dr. Suffren has been just a huge champion in this area of really trying to help us understand what is the scope of this problem in our country, because as I said, we just have not great data in terms of surveillance of the scope of this issue. So what do we know about incarcerated mothers in general? While we don't know a lot about pregnant inmates specifically, we have a growing body of evidence about incarcerated mothers in general. And so I just want to share a little bit about what do we know about moms in prisons and jails. Among incarcerated mothers with minor children, we know that they have a number of socio-demographic and contextual risk factors that really have important implications for maternal and child health, and we can extrapolate that to thinking about pregnant women in particular. So among incarcerated mothers with minor children, for example, 10% of them reported a period of homelessness in the year before their incarceration. More than a third of them reported government transfers such as welfare, Social Security, or compensation payment as income. This becomes important when we think about, right, what may happen, the collateral consequences of an incarceration. So if a third of the mothers are receiving welfare, Social Security, or other kinds of government resources, and the mother becomes incarcerated, those resources may no longer flow to the child and the family system. We know, thinking about environmental risk still, we know about 1 in 5 incarcerated mothers reported receiving income from illegal sources prior to their incarceration. In the month before their arrest, most incarcerated mothers reported earning less than $2,000 a month. So when we think about sort of the socio-demographic landscape and the environmental risks of mothers in this context, we know that they're experiencing a number of risks. Thinking about physical health, half of incarcerated mothers have a current medical problem, and 64% of incarcerated mothers report any substance dependence or abuse. And so when we think about some of these issues, right, homelessness, poverty, limited employment opportunities, we know that this is a very vulnerable group of women. And we can look at this list and we can look at these risk factors and we can think about the maternal risks, and we can think about the impact of these co-occurring and cumulative risks for health and development of the next generation. And really, this becomes important in sort of the crux of a lot of my work, thinking about how are these risks transferred across generations, and what are the circumstances under which an incarcerated woman comes to prison pregnant. A small but growing body of evidence suggests that pregnant prisoners are at increased risk for poor prenatal outcomes and are less likely to receive adequate prenatal care. These outcomes are due, at least in part, to these co-occurring risks that they experience, which I've just talked about, including toxic stress, exposure to domestic violence, substance use, and other traumas. And there is, given what we know about all of these risks, it's an easy thing to think about, well, then what are the opportunities, or where are there ways in which we can intervene? And so given all of these risks, the project that I'd like to share with you today in thinking about some of our work is the Minnesota Prison Doula Project, and I'll walk through a little bit about the work that we're doing here in Minnesota. So some numbers just to give the context. I know that I don't see a lot of Minnesota folks on the line today, or names that I recognize, but I want to give a little bit of a lay of the land here in Minnesota, and I think it's important to put into context. So in 2015, we had about 674 women who were incarcerated in our one-state prison. We know from data that we've collected here in Minnesota that 77% of them are mothers with minor children, and about 6%, between 5 and 6%, report that they are pregnant upon their admission to prison. And I just want to pause here and recognize that I just told you that the national data say that there are 3 to 4% of pregnant women, and I told you about the PIPS project. I just think it's really important for folks to understand that this is a place where we know we in Minnesota have worked really hard to collect data about the scope of the problem, but it's really a challenging issue, and it's really hard to think about intervening or providing services across many states when we really don't have a good lay of the land. It's getting better, but certainly there are many of us who are clamoring for better data. On the right-hand side of the slide, you can see changes in our prison population, which mirrors what we've just recently talked about the exponential growth over the last 30 years. In Minnesota, women in our state prison range in age from 18 to 80, but you can see the average age there is 36 years. Women in our prison are disproportionately, as they are across the country, from racial and ethnic minority groups. I want to point out here the disparities because they're really stark and it's really an important piece of this puzzle. So, for example, although Black adults make up about 5% of our state's population, they're 17% of our state's prison population. And in Minnesota, American Indian and Alaskan Natives make up fewer than 2% of our state's population, but they're 18% of our women's prison population. And I think this is really important when we think about maternal and child health, health equity, and systemic disparities and systemic racism that is happening in these systems. This is a really a sobering picture of the state of our correctional facility. Again, less than 2% of our state's population is American Indian, Alaskan Native, and almost 20% of our women's prison population. What else? I'm just going to turn now and thinking about this group of women and what we have been doing here with our Minnesota prison population, our state, the pregnant women in our state prison. So the Minnesota Prison Doula Project was started now more than 10 years ago. My colleague who I mentioned in the beginning introductory remarks, colleague and dear friend Erica Garrity, was a clinical social work intern at the women's prison when she observed that pregnant women were looking they had a lot of feelings of isolation and sadness. Pregnant women were being housed all over the correctional facility. There were no targeted or specific resources for pregnant incarcerated women. And so what Erica did was bring all of the pregnant women together and hold talking circles with them and ask them about what they would like to see in terms of services or resources for them in order to get what they needed to be supported during their pregnancy. What grew out of those talking circles were two core components of our original prison-based doula project. One is a new moms group, which is a group-based support and education program, and the other one is one-on-one doula support. And today we're going to spend the majority of our time really thinking about this new moms, the doula component, but I'm happy to share more information about our new moms group at another time or if people want to hear about it. Just briefly about the new moms group, it's a weekly 2-hour sessions on a 12-week curriculum, and really the goal here is to help increase women's knowledge about their reproductive health and the physiology of pregnancy and birth, increase women's tangible parenting skills and their life skills, and increase the support that they have from peers who are also pregnant or recently pregnant, and professional staff associated with the program. We really try to each week introduce an educational component. We try to create a warm and nurturing space for women to share with each other about their experiences, model empathy and encourage accountability, and create a safe space for women to learn and support one another. The doula program is one-on-one doula support. For folks who may not be familiar with a doula, we think about a doula as being a professional, a non-medical birth support specialist who provides physical, emotional, and informational support. For our program, this looks like a couple of different things. So for us, pregnant women who are identified by pregnant at the facility are matched with a trained doula, again a non-medical birth companion, who provides a variety of support from the prenatal period, from when she is referred to the program, throughout her pregnancy and into the postpartum period. A growing body of evidence, including a systematic review by Hodnett and colleagues, has found that women who received continuous intrapartum support had shorter labors, were more likely to have spontaneous vaginal deliveries, and were less likely to report dissatisfaction with their childbirth experiences. And so given the increased risks of the women that we work with, doula care may be a particularly promising approach to incarcerated women. So our doulas aim to meet one-on-one with their clients at least twice in the prenatal period. And these meetings include prenatal education, emotional support, assistance with preparing a birth plan. They provide continuous labor and delivery support. So our doulas are called by the watch commander, or the person who is monitoring the facility when a woman goes into labor and is transferred to the local hospital. Our doulas meet with the client at the hospital after she's transferred from the prison to provide emotional support, physical comfort, and assisting the mother with making informed decisions throughout her labor and delivery. Our doulas, unlike doulas in the community, have the unique role of providing support during separation. So 48 hours after a woman gives birth for a vaginal delivery and about 72 hours after a C-section, our doulas return to the hospital to provide support when the mother will be separated from her infant. Again, I want to remind folks about that reproductive justice framework that we talked about in the very beginning. This is a very difficult and emotional time for our clients. So most of the mothers have identified a relative in the community that will come and pick up the baby, and the mothers will go back to the prison where the babies go home with the elected caregiver in the community. There are some really important opportunities here for local public health to be engaged, which we can talk about as we move forward. In addition to providing support during the separation, our doulas then provide postpartum support back at the prison. The doula aims to meet with the mother at least twice after she returns to the correctional facility. And I think it's important to remember here that our clients are also returning to the group-based support. So in addition to getting one-on-one support with her doula, the client is having an opportunity to process the birth with the group in a group setting and getting support in that way, sharing her birth story, et cetera. I'm cognizant of time, so I just want to briefly give a little bit of update about our program. Over a 5-year period, we supported 67 pregnant incarcerated women who were matched with a doula. You can see here, if you're remembering the stats from before, that these clients are younger and more racially and ethnically diverse than the state's prison population in general, and they have on average fewer years of education relative to the rest of the prison population. We know that this is a group of moms who has considerable risks. So you can see here that 72% of them have received some kind of mental health diagnosis. 60% have self-reported that they've experienced domestic violence. 22% of them report having another chronic health condition, and 19% of them report that they're working with Child Protective Services. I often get asked here about what that means to be working with Child Protective Services. That's not necessarily that that Child Protection or Child Welfare is involved with this baby or this pregnancy, but it may be that they have engaged with Child Protective Services for another child, or that they're working with them in terms of case planning for other children or for this current pregnancy. We have been collecting outcome data all along about our program. At the 12-week follow-up for the group-based support, we see that women report significantly fewer depressive symptoms. They self-report more confidence as parents, more support from other women at the prison, and more support from prison staff, which we think is particularly interesting given that prison staff aren't actively involved in our project. But we do think that we've supported every birth since 2010, and we think that there's a lot that's changed in sort of the culture and our staff being physically and emotionally present, and establishing working relationships and collaborative relationships with prison staff, that there is a lot that's sort of systems change that's happening that we haven't really been able to capture quantitatively. I'm just going to skip that slide and here talk briefly about our visits, clients' visits with their doulas. You can see here that these prenatal visits last about an hour. Doulas are with their clients for the labor and delivery, what we have labeled here the birth, about 8 hours on average. They're there for the separation visit, 3.8 hours, and those postpartum visits are, again, about an hour back at the prison. one of the clients said, having a doula there made my experience a good one. It helped a lot. You have to find something positive about your birth experience while you're in prison, and my doula helped me achieve that. People ask a lot about our labor and delivery and neonatal outcomes, and so I want to just talk briefly about those here. Here you can see data in terms of mode of delivery and neonatal outcomes, as well as baby outcomes, gestational age, and birth weight. We have so far have had, despite all of the risk factors that many of these women are experiencing, we've had really promising outcomes. So the overwhelming majority of our moms have spontaneous vaginal deliveries, and you can see that of the C-sections that have happened, 13.4% of our clients have had scheduled repeat C-sections. And as a key metric, thinking about trying to reduce the number of primary C-sections, thinking about helping women understand the risks of cesarean deliveries and make informed choices. This is something that we're proud of and is certainly promising in terms of our project. You can see that we have healthy babies, very few preterm or low birth weight babies, and this is important again when we think about neonatal outcomes and risk factors for infant health and development and really life course development. Let's see here, just switching slides. I'm going to skip this slide and just tell you briefly that we have really been working to identify great comparison data for our Minnesota project. The research nerd in me says the within subjects data that we have and the relatively low rates of cesarean deliveries relative to state averages or national averages are great. But there's a lot of this paradox of the correctional facility in terms of protection potentially is really that. It is a paradox. So we don't think about incarceration, correctional facilities being an ideal setting for pregnant women. But we do know that incarceration does provide some quote-unquote protection in terms of meals, housing, often protection can be protection from violence, domestic partners, and for some women does provide maybe the only provision of medical care that they've received during their period of pregnancy. And so there's been some that's been written about, well, maybe there are circumstances under which pregnant women do better in an incarcerated setting. And I'm not arguing that that's the case. I just think it's important for folks to understand that there are some provisions of care that exist in a correctional facility that many women weren't accessing into the community or didn't have resources to access. And I think that Dr. Suffren does a really nice job in her book, Jail Care, of talking about this challenge and the failed safety net in our communities for many women, particularly low-income women and women of color, and being able to access reproductive care and have the resources that they need to be supported, their health and the health of their babies. So all that is to say that identifying a comparison group for our women has been really challenging. States don't collect data. We cannot ethically and would never think about randomizing women to receive doula services or not. And so what we've been working on now is this electronic health record study where we are extracting health records from our participants and a historical control group. These are women who all delivered their babies. They were incarcerated in the same prison and all delivered at the same local hospital. I mentioned that we've supported every birth since 2010 forward, and so we can really think about this historical control group of the women who, again, had the same conditions of confinement and the same treatment in terms of prenatal care at the prison and hospital care, and theoretically the difference being whether or not they received doula support. So we'll be doing that in the coming year or so, assessing differences in labor and delivery and neonatal outcomes and really trying to document short-term costs and benefits of our program. We've also been expanding and adapting services to local county jails across our state. This has included community-based doula supports, as I mentioned in my opening comments, and I showed you that the whole pie from the Prison Policy Initiative. the circumstances of jails and prisons are quite different. And so what this has meant is that we've needed to really adapt our prison program for thinking about what that looks like in a local county jail. So if a woman is referred to our program when she comes into contact with a county jail, how do we provide support for her upon her release into the community? Many of our women have also talked about having one-on-one peer support or supportive counseling where they can meet with a doula and just talk about parenting on a one-on-one way, even if they're not currently pregnant. And then in one of our partnerships right now with the Ramsey County Jail, where St. Paul, Minnesota is, we've been able to do supportive visitation where moms can have one-on-one contact with their kids, and our staff can provide a really nurturing and welcoming space for that mom and her child to have developmentally appropriate, family-friendly visitation. And so our staff has worked in collaboration with the jail to develop that portion of the program. We've also been really working to try to document pregnancy rates among incarcerated adults in local jails. And so in March of last year, we did a point-in-time estimate survey attempting to really understand how many people are pregnant and parenting in local correctional facilities. Among mothers, 6% of them report that they're currently pregnant and 5% say that they don't know. And among fathers, 9% of them report that there's a partner pregnant, and 6% of them say that they don't know whether or not their partner is pregnant. As Reagan mentioned in her opener, and I'll just say very briefly about this, we've had some really interesting policy work that's come out of our work in a way that maybe I didn't fully anticipate or appreciate as it was all happening and unfolding. And looking back now, it's been exciting to see how much progress we've really made. We had some legislation introduced during the 2014 session regarding the needs of incarcerated women related to pregnancy and childbirth. And that rolled out new mandates effective in July 2014 for our state prison. And the legislation gave the jails 1 year to come on board. And so everybody is now under the same law in our state pertaining to the care and treatment of pregnant incarcerated women. This established a legislative advisory committee in our state, and we met consistently for a long period of time and are actually continuing to meet now as we talk about two specific issues in our state. One really important issue that we've been diving into recently in terms of opioid use disorders among pregnant incarcerated women and how our jails are handling this group of women, and how are we supporting them and the really complicated challenges between correctional health care, hospital care, community-based care, substance abuse treatment, et cetera. We held an interdisciplinary institute on the reproductive health of incarcerated women, and I just want to point out here that our Center for Leadership in Education and Maternal and Child Public Health at the University of Minnesota recorded that institute. Everything is available on our website, and so all of the talks are there, and a policy brief and a Healthy Generations all devoted to that issue, and those are resources that are freely available online, and we'd love to see folks use. Real quick, in terms of the key elements of our legislation, the language included limits to the restraint of pregnant incarcerated people, mandates offering pregnancy test and prenatal standards of care. The law mandates access to mental health care and screening, prenatal education and birth support, and some very small amount of funding for birth support. We didn't fully anticipate, and it's been, again, very exciting for us to see the Minnesota legislation become a model across the country, which has been wonderful. I think that a lot of the hard work that our Legislative Advisory Committee did to come together as diverse stakeholders, as an interdisciplinary, interprofessional team to put forth our legislation in Minnesota really is a model. I mean, this is a complicated issue, and certainly one that we're just scratching the surface on here in 45 minutes, but a really complicated issue that I think we've been able to make a lot of progress on, and recognizing that there are really diverse stakeholders in terms of correctional health providers, corrections administrators, maternal and child health professionals, substance abuse counselors, et cetera, and everybody coming together to think about what is it going to take to put our best foot forward in terms of this legislation has really been exciting. In addition to policy with a big P, we've had some really exciting things happen too in thinking about other changes that maybe we didn't expect. And then just a shout out here to thinking about the importance of basic data in terms of answering critical questions. So as our work was rolling out, I got a call from the Director of Health Services for our Department of Corrections, or an email, and she said, "What's the average time between delivery and anticipated release date?" was her question. And it's interesting to think about this. What is the average time between when a woman delivers her baby and when she's getting out of prison? The first answer is 302 days, or about 10 months. And so, as a developmental child psychologist, I think about, well, what is happening in the first 10 months of that baby's life, and the separation between mom and baby? There's also a huge range, right? So the second answer is, well, it's less than 1 month for some to 33 months for others. And then the third answer that I gave here was, wow, actually 60% of these moms are getting out within 6 months of the birth of their baby. What are the implications of that, right? When we think about really not being able to breastfeed, or not being able to have consistent daily contact and build a bond with one's baby over the first 6 months. And 80% are released within their baby's first year and a half of life. And so again, when we think about what that means for moms to really have relationships with their babies, the overwhelming majority of people that we lock up in this country are getting out and plan to resume parenting roles. And so when I think about what that means for supporting them and their children during this period of time, there's some really important implications here. We know those data in particular were really relevant for the Department of Corrections here in Minnesota, thinking about breastfeeding intention and initiation. Many people have asked, so for our moms, about half of them report that they intend to breastfeed at the hospital in that short period of time that they have with their babies. 64% of them initiate breastfeeding at birth. And we have some data to indicate that breastfeeding support is more common during breastfeeding support. Our doulas are often talking during one-on-one meetings with their doulas about breastfeeding and lactation support. And so we've been able to leverage expertise here in Minnesota at our hospital for lactation support, to pair up with the lactation specialist at the local hospital to get some resources into our groups, to get resources into the prison to be able to really support this. Briefly here, and I just want to thinking about sort of really honing in on the implications for local public health. And I've mentioned some of these as we've been moving through today's time. But before a woman comes into contact with the criminal justice system, or before they become incarcerated for any significant period of time, I think we can think about, and I often talk to local public health professionals, say, we're seeing these women. We know who these women are. We know who these families are. Good evidence, right, of course, to show that evidence-based home visiting and nurse-family partnership has data on this, that nurse-family partnership, nurse home visiting specifically, reduces maternal risk for criminal justice involvement, and certainly has two-generation effects in terms of reducing their children's risks for juvenile justice involvement at age 15. So what are the opportunities when we think about expanding nurse home visiting for high-risk women in general, not just those who are justice involved? And certainly thinking about other community-based resources like WIC or supplemental nutrition programs in general, where we might see families at particularly high risk for justice system involvement, where we can see opportunities for prevention and resources and support on the front end before they come into contact with the criminal justice system. During incarceration, I've seen really innovative and fantastic models for local public health collaborations. In some communities and some states, local public health professionals are going into the correctional facilities and providing parenting education groups, providing support groups during periods of incarceration. Also opportunities to leverage expertise and training in terms of breastfeeding education and resources. I saw Sarah O'Connor Bennett is on the call today from Illinois, and thinking about really innovative work that's happening in Illinois to use Illinois Department of Health resources and expertise to get breastfeeding education, breast pumps, and other resources from public health into the correctional facility. And I think therein lies the opportunity where we can see these state-level systems or community-level systems intersecting and interacting to really think about the intersections between public health and corrections. And then after, thinking about ways in which women can be referred for community-based resources post-release. Correctional facilities vary considerably in how women and parents in general, or incarcerated people in general, are prepared, and I'm putting prepared in air quotes here, for release. And so what are the opportunities for referring to community-based resources post-release? How can public health help with that, whether that's helping fill out insurance applications for public insurance or helping them identify where their local WIC offices or identifying family housing resources and general reentry support. I think those are really important places where there are lots of opportunities for local public health to be engaged and really support this group of women. I will just stop here. We had a few technical difficulties, but I think we've still got some time for questions, and I will just stop here and take some questions. Thank you for your attention. It looks like one question has already come through on the chat, and so I'll go ahead and take that one as other people are thinking through. Ebony asks, when these mothers initiate breastfeeding, do they have support to continue breastfeeding, and how do they ensure that infants get the milk, ship breast milk to the babies? Great question. So part of our work in Minnesota has been to push this a little bit further than where it was and where it's currently at. So several years ago, before our work started, there was really no support when women returned to the facility for anything regarding lactation. Now we've made some progress. Women have access to breast pumps, and again, collaboration with our lactation consultant at the hospital. But unfortunately, they can only use the breast pumps to pump and express and discard their breast milk. Other states, other jurisdictions, some of our county jails have great policies in terms of milk storage. And so Alabama, for example, has just recently been working, the Tutwiler Women's Prison has been reworking their breastfeeding policy so that women can pump and store their milk to be able to get the milk to the babies in the community. And so different states are doing this in different ways. Different communities are doing this in different ways, and I think this is a really great place for local public health to share and lend their expertise in the way that this could be done better and help correctional facilities, because they're just not equipped to really handle this. Another question was, how are doula services paid for? That's a great question. We do pay our doulas, and this has been an important part of sustaining our program and sustaining our staff. We have funded our program through a variety of sources, including grants and fundraisers and gifts and donations. Our original project was funded through a community university partnership through our Clinical and Translational Science Institute. We've also gotten funding from our program in health disparities research, and then some really generous donors here in our community, including the Otto Bremer Trust and the Women's Foundation. We've tried to be very strategic about seeking money for both the research and the science side of this, and obviously all of the direct support, the direct service piece. So that's been an important part of our project as well. Someone asked about the name of our curriculum, and that's a great question. So we've actually developed the curriculum, and it's available. We can certainly post links to that. So our curriculum has been developed and really co-created with the incarcerated women who we work with. It's 12 weeks, and we talk about everything from your body, your birth, to some breastfeeding stuff, what to expect with a newborn, and opportunities to connect with your baby from a distance. And so we can certainly post links to that. Another question related to that was, does the doula also administer the curriculum as well? And if not, who does? So we have two group facilitators every week. One is Ray Baker, who I mentioned, our program coordinator, who's been consistently doing the group since the beginning. She's also one of our doulas, although as her time has gotten busier and busier, she takes fewer clients. And then we rotate a doula in, typically another doula in to co-facilitate, which has been great, because then the moms in the group have an opportunity to meet the other doulas and to hear diverse perspectives. Susie asked how many of the infants that go to the NICU are due to methadone or opioid exposure in utero, and that's a great question, and I wish I knew the answer to that actually. I don't know, and it's something that because we haven't documented as a program, those data are very, very hard to come by. It's something that we'll hope to dig into with our electronic health records study. So Reagan, I think I've gotten all the questions in the chat box. If there's anybody else on the line who has questions, certainly feel free to use the chat box here in the last few minutes that we've got. And it looks like Reagan has also reminded us that we can unmute the line by pressing *7 if anybody would like to chime in. Otherwise, I guess I'll just say in conclusion, it looks like somebody's going to chime in here. I will just say in conclusion, really, we're happy to be a resource here in Minnesota, happy to share our resources, share our brains. Our team hosts a national network call on a quarterly basis with community stakeholders, doulas, birth workers, advocates across the country who are interested in doing this work. And so I'm happy to continue to be a resource or have people join that call. And then I'll just take this last question here from Deborah. Is there any access to continuing contraception for women who are on it when incarcerated in Minnesota, i.e. injectables or oral contraceptive pills? That really depends considerably by correctional facility. And so that's a great question and a complicated one. And because I'm not one of the healthcare providers at the facility, I certainly don't feel equipped to answer exactly what's happening. More and more across the country, more and more facilities are thinking about long-acting reversible contraceptions for incarcerated women and helping make informed reproductive health decisions. I know that there is growing conversation about making sure that women have access to reproductive or to contraception upon release, and to being prepared and having those conversations with their providers pre-release. But truthfully, I'm not exactly sure what's happening in terms of continuing contraception for women who are in our prison or what's happening at the local jail level across our state. And then Kelsey asked, can you share again what the legislation required to be established in the prisons? Sure. Yes, our legislation mandated, I'm just going to see if I can flip back to this slide here, limited the use of restraints on pregnant incarcerated people, and so that means that no pregnant woman can be restrained, shackled at any point during their pregnancy, labor and delivery, or in the postpartum period, 48 hours postpartum. If a woman does need to be restrained in any way, they have to use handcuffs in the front of the body. So pregnant women cannot be handcuffed behind the body, and the handcuffs have to be used in such a way that they can break their fall if they do fall. Our legislation also mandates that pregnancy tests are offered within 14 days of one's admission to a correctional facility, and so that provides women with the opportunity to identify their pregnancies early. Of course, they can decline the pregnancy test. It also mandates community standards of prenatal care and access to mental health screening and treatment. and then has legislative language included about access to prenatal care and doula support. So no correctional facility in our state can decline a woman's access to a doula. If she's pregnant and incarcerated and wants a doula, she can be referred to our program. The correctional facilities don't pay for the program, although we are working on contracts with several local correctional facilities. But a correctional facility cannot decline or deny a woman having access to a doula, which is important. I think those are the key pieces of the legislation. So we are right at 2 o'clock. Thank you so much for your time and your attention and your interest in this topic. Again, I'm happy to be a resource here in Minnesota or across the country if folks are working on these issues. We're really also excited. This is complicated and difficult work, and so we're happy to make connections and share with other people and brainstorm, and we certainly don't have all the answers here in Minnesota, and so we'd love to learn what other folks are doing around this issue across the country. And so if you're doing something innovative or exciting or just want to talk, please don't hesitate to reach out, and we're excited to hear from you. Thank you.